llamo Oliver, tengo 27 años y me diagnosticaron de VIH el 5 de octubre de 2018, cuando tenía 25 años.
Me llamo Mar Linares, cumpliré en breve 58 años y estoy diagnosticada hace 31 años.
Soy José Fley, tengo 29 años y me diagnosticaron VIH el 12 de agosto de 2016.
En aquella época, pues mira, te hacías la prueba, era positivo, pues te vas a morir, adiós.
Porque la discriminación continúa existiendo. Nosotros en el comité de Salamanca hemos tenido varios despidos por tener VIH.
Tú has tenido que batallar con 3 estigmas.
Y qué duro muchas veces también es escuchar como una de las personas que más te conocen en esta vida, ¿no? Como puede ser una madre, te diga, ya llegará el momento en el que seas feliz y encuentres tu lugar.
Bueno, ahora que hay tanto, ¿no? Como tanta restricción, nosotras por lo menos, cuando nos moríamos juntas nos podíamos abrazar.
Sí.
¿No? Que sí, eso sí que no nos lo quitó el diagnóstico del SIDA, ¿eh?
Sí, pues menos mal, porque yo recuerdo y que casi cada semana o 15 días faltaba alguna y cómo nos acompañábamos a morir.
A morir, sí.
Eso lo tenemos ahí.
Aprendíamos a morirnos juntas, sí. Luego aprendimos a vivir.
Que también
es súper importante también.
Sí, jolín. No se queda más fácil de las dos cosas, ¿no?
Yo también desarrollé un miedo a la muerte, ¿no? Yo también tenía miedo a dormirme porque a lo mejor no me despertaba. O sea, yo no quiero dar pena, yo al final lo que quiero es conseguir ser igual al resto de personas.
Es que cualquier persona te puede decir a ti que tienes VIH por el hecho de ser mi pareja.
Tienes que mirarlo como un conjunto, ¿no? Y así nos damos cuenta de qué nos hacemos como personas en esta sociedad y lo hacemos con todo, lo que decíamos al principio, con todo lo que es un poco diferente de lo normativo, heteronormativo, hombre blanco, heterosexual, occidental.
So can I have my presentation on, please? Good morning. These are technical hitches that happens to everyone. Okay, so first of all, I would like to welcome you all. And before that, I want to remind you that this symposium will be in English and in Spanish, and both, actually. Some parts will have both languages. So you have 2 channels in your headphones to listen to the translation. And this is the Spanish channel and the English channel. Okay, I didn't click the slide, but now it is. Here we go. Very important for this session is that you can go to slido.com, enter that code, the passcode, or scan the QR code that you have on slide, because this is an interactive session. We will be asking you questions, so it's good that you are logged in so that you can follow and participate. So, are you all logged in, Slido? Okay, great. So I'm gonna move on. So if you couldn't log in, just let me know and I'll go backwards. So welcome, as I said earlier, to this session. It's a session in which we will be working on stigma and how to eliminate it. This is the agenda for today. We have different slots in the agenda, and we will try and discuss with you, do presentations, and talk about how we can arrive to action to achieve zero stigma. Our speakers today are, as you can see on the slide, myself. I am María José Fuster. I am the Executive Director of Spanish AIDS says Sida, and the University of the National Open University in Spain. I'm also a woman who lives with HIV openly for 33 years. We also have with us Erika Castellano. She is unfortunately not been able to be here in person, but she's online, and I'm sure we will be seeing her shortly. Erika is the Executive Director of Global Action for Trans Equality in the Netherlands. We also have very well known in Spain, Diego García Morcillo, super well known, Director of ADARA Spain, here in Sevilla Checkpoint. And we've used it profusely. It's been used in all sessions in the conference. We also have Dr. Vanessa Appiah, a consultant physician with a wide experience in clinical setting and research. She's senior director, and I cannot read in English all her merits, so read them on the slide because unfortunately I cannot get there. These are our disclosures of us and our organizations. The meeting objectives are to discuss the various types of stigma and the impact stigma has in different populations and settings. We want to share examples of work that have successfully managed to reduce HIV stigma. And above all, we want to create a forum with our panel members and the broader community to engage in discussion about the remaining challenges and how we can build on past successes to achieve zero stigma by 2030. So these are our ambitious objectives. And the first thing we want to share with you is a question slider. Thinking back into a time you felt stigmatized, and how did that experience make you feel? It doesn't have to be HIV-related stigma. It can be because we were the fat girl or boy in the class, or the cleverest boy or girl in the class. So think about a point in your time when you have felt stigmatized, and tell us how you feel. So all you have to do is say one word, one feeling. Oh, I can see that there are some words. This is faster than I thought. This is amazing because this is based on a qualitative word analysis, meaning that the bigger font word is the word that has been most widely used among the answers. So it means that most people felt isolated. The isolation that stigma brings upon us, and anxiety, sadness, to feel dangerous, sad, different. The question of being different is wide here. Fear, anger. So it's quite clear that we have very negative feelings associated to this stigma, and we need to tackle them. So the best thing is to see where we are now. And to do that, we are going to give the floor to the first presentation by Dr. Vanessa Appiah, and then we will listen to our next speaker. Diego.
Maria Jose, and thank you. I am going to talk about stigma in its broader context and drawing it into stigma and HIV. So when we think about stigma, and we do think about it in its broader context, it's really a complex but social phenomenon. And I think that's so important. And when we think about the definition, one of the definitions I really like is that it involves distinguishing people based on social statuses such as attributes, illnesses, and identities, and socially devaluing, discrediting, and excluding individuals with those statuses. And when we look at different forms of stigma, we can see some of the more key aspects of it in terms of interpersonal, societal, internalized with self-stigma, looking at the structural context and institutional, but then how that manifests into anticipated stigma, be it perceived stigma and experienced stigma as well. But then what does this do? Well, this is why we're here, because it has negative consequences on physical and mental health. But most specifically in HIV, HIV remains one of the most stigmatized but also misunderstood health conditions. And I'm sure that many of us will all agree that it undermines all we do in the sector, and it's one of our greatest challenges. But when we think about stigma in itself, we cannot not think about health inequalities and health inequities. And when we think about health inequities specifically, it's bringing that aspect is that it's unjust. There are unjust differences. So stigmatized groups experience worse health and greater health risks than those non-stigmatized. And that really then undermines people accessing care, and then also leads to harmful, affective, cognitive, and behavioral and physiological responses. And we know that then you bring health inequities, you bring stigma, and then you bring HIV, and HIV in itself disproportionately affects those groups typically stigmatized. But we can't look at this in isolation, because it's those social and structural factors and those social determinants of health that are really crucial here. And for me, stigma really rests on and is reinforced by societal power structures, and that's fundamental to its manifestation. So when we look at HIV and its, stigma in its broader context, and then we think about how we're going to respond, what's really crucial is that we have to recognize that individual lived experience, and there will always be shared vulnerabilities between individuals and within communities, but we really need to understand that intersectional experience when it comes to stigma. And what that means is that people living with HIV will encounter different intersectional stigmas. And there's a convergence. So there are multiple layers of oppression that people may experience, be it due to their sexuality, their ethnicity, age, ability. Those all overlap and intersect and can be additive and multiplicative, I managed to say the word, and they all reinforce. But what's crucial here is that as they converge, you bring HIV into the mix, and that then adds its own challenges and into their lived experience as well. And whenever we think about something that's complex, we always want a framework. We always want to think about how can we influence, how can we change? And there are many frameworks, but I particularly like this framework, which we discussed as a group, which really highlights the drivers and how it manifests, and then also the outcomes as well. But it also identifies points of influence that we can all act on. And within here, I just want to move on to some good practice that is happening in the UK that some has already been discussed already, but I think just ties it together as we think about how we move forward. So what's key to stigma is understanding, measuring, and mitigating, and then preventing and excluding. And when we look at when we think about that framework, there are many opportunities in these domains for interventions. And I'm just highlighting some here. So specifically with Fast Track Cities and London, and with the National AIDS Trust, we rolled out a national survey looking at public attitudes towards HIV. The key concept of collaboration, of bringing stakeholders, community stakeholders, policymakers, clinicians, all into one space is clearly identified with the HIV Commission. Research that is identified there, and different programs that really bring key influencers into the mix. And so thinking about how we get the information out there, how we reinforce skills building amongst both people living with HIV, but the wider world as well, harnessing lived experience, which cannot be underestimated. And I think one of the key themes within the conference is really authentically harnessing people's lived experience and letting it translate into the interventions that we design. A review of practices and policies, recognizing that the social structural context is crucially important, as is the legal context, the use of influencers and opinion leaders, but a fundamental community co-production and co-delivery, but true co-production and co-delivery. And so we talk about getting to zero with stigma, but I think that it's moving towards that, away from that narrative of simply getting to zero to getting to acceptance, belonging, true inclusion, and being respected. And I've done a whistle-stop tour of some of the successes, but there are many successes, but definite clear gaps in impact of interventions to date, which we'll be going through. But just to highlight some of the challenges, you know, measuring stigma is really difficult, and then measuring the influence that you've had with your intervention with stigma is difficult. So how do we do that effectively and evaluate our interventions robustly? How do we achieve sustainability? And for me, one of the key things is distributive justice. So it's fine, we're talking about stigma, we're talking about marginalization and health inequalities, but then do the resources and the funding follow this? And do we center the most marginalized within our funding? Place-based and sector-based challenges are crucial, but it's really important about that really focused, broader systemic change. And how do we do that in parallel at the same space? And I think this conference really does highlight the importance of that global approach, that we have some successes in one area and we need to learn from another area, but also we need to engage the diaspora, because within all our countries and our locations, we do have diversity there. So engaging the diaspora is crucially important. So as we move from the challenges and just reflect on that, I have highlighted about sharing and collaborative working. So I just want to hand over to my colleague, Diego, to talk about the experience within Spain. Thank you.
Thank you, Vanessa. Thank you, Maria José. Thank you, the organizers, for inviting me.
When Maria José was asking the audience about how they felt when they experienced stigma, some people said different. And different sometimes is lesser, if you know what I mean. Different means not having access to things the general population has access to. And that is a true barrier, which, as you will see, has a lot to do with the mobilization to change it, the mobilization of the community, but also with politics, with the political will and determination to change things. We must stop being different, and we must stop feeling less and be more equal. That's the most important thing. I've stolen the presentation from Anna Curtin, just to let you know, plain honest. So she did a great presentation when we were talking about zero discrimination, about how they had developed the process of social pact. So after I saw that, I wrote to her and I said, listen, Anna, please, can you please give me permission so that I can use your presentation, your wonderful PowerPoint in this amazing symposium I'm going to, or the Fast Track Conference? She said, of course, Diego, go ahead, you can use it, because it belongs to us, it belongs to the community, to be used by everyone. And this PowerPoint really reflects very well the process and the steps taken along the way to change something which is crucial in Spain, to stop feeling less in many matters, and that is thanks to the social pact. Look at this, 27th of November 2018, as a key date, because it was actually. It's when the social pact was established, but there is a long story behind that. It happened way, way earlier than that, in 2011. In 2011, the civil society in Spain started, the different stakeholders started meeting to say, we are detecting that in Spain, despite we guarantee rights of HIV people, there is still a long way to go and a lot of work to do. So, as it happens to with things, there was a political change and there was sort of like a stagnation because we didn't have the political will to change things. That is why the community can push, but the political will needs to be there. We need a political vision to be there. And then is when we feel the anger, rage. Those are words that happen amongst us when we feel frustrated. In this meeting, you see Julia sitting there because she's a great forerunner of the Social Pact for Non-Discrimination and Equality. And she's one of the persons who made it possible. So it was when, together with the Minister of the Interior, the President of CECIDA, former Minister of Health, and Regional Minister of Health of Aragon government, they kicked off the beginning of this social pact. The goal of the social pact is to be the same, but to give it more flamboyant technical words is to eliminate stigma and discrimination associated with HIV and to ensure that people living with HIV in Spain have full rights. And you may say, how come in a Western civilized guarantist country you can say that? Well, we didn't have full rights. And you look it up and you say you live in a country which you are supposed to be really giving all possible guarantees, but no, we didn't have all our full rights. So that was the beginning of the research. Lines of action: promote equal treatment opportunities, social acceptance to reduce the impact of stigma, and to generate knowledge to see what needed to be changed and what needed to be transformed to be more equal. Obviously, there was an executive organizing committee, and we launched the pact for people to join, both individuals, organizations, and institutions. And as you can see, it's quite a huge number of institutions and individuals who adhere to this social pact. And to achieve those adhesions and members, we created an online communication plan trying to explain in a simple manner what the social pact was all about, so the organizations could go to the website, find out more about it, and understand that they could, go for it. What advances have occurred? What are the main inroads? We needed to mobilize different ministries because, of course, when you start thinking about things that we are not the same or what competencies are affecting the ministers, you need to do a lot of mainstreaming. So we needed to do an analysis of the legal norms and standards in Spain to see which ones are discriminatory. And we had to analyze in the private labor market if we effectively have the same rights or not to have a normal standard job, or if we are penalized or sanctioned because of having HIV. And we created materials for awareness raising on stigma, discrimination, and HIV people rights. So in that slide, you have a look at the huge amount of ministries that were involved in Spain. And these are just national ministries, but then you had, within a ministry, you had lots of sort of like infrastructure. So it's like a whole huge algorithm of different departments and people you had to bring together to convince to change things. But please look at the center, how you can see the community. We have always felt at the center because it started from us, and fortunately we were very lucky that we were listened to by the authorities, which were very ready and willing to listen to us. In the past, they didn't used to listen to us that much, but then they did. So that was good. So because we felt we were less, if you know what I mean, we couldn't access to certain positions in the public authorities. There was a veto for us. We couldn't go into the state force, armed forces. We couldn't be part of the jail system or the penitentiary jobs. And then you need to find allies. What happened with HIV is not just us. There are other people with other infections and diseases who also feel the same discrimination. So we found the alliance that helped us to change not only the law for us, but also laws which are also affecting other people. So this is a matter of human rights. So it's not just HIV, it's more wider human rights. I want to highlight this as an important milestone, because it was going beyond HIV. Another advance or achievement is that now that we are talking about aging, comorbidity, chronicity, etc., another achievement was like, oh, I'm old. Where can I go to? Because they don't allow me to go to an elderly home. I can go to an elderly care home. So what can I do? I mean, I'm old, and then fuck you, literally, he said. So that can't be the case. So we fought to change those instructions that some regional governments had, in which, in a hidden manner, they avoided HIV people going to care homes for the elderly, which are social and health infrastructure. And thanks to the Social Pact, we managed to change this discrimination, which was ridiculous and inhuman. Then the pandemic stroke, 2020, well, that was a bypass or sort of like standby period. But after the pandemic in 2021, we started working again. And one of the key things we did was to do a study to analyze whether the Spanish society had changed or not their attitude and beliefs regarding HIV people, HIV/AIDS people. I think the study's finished. Maria Jose has recently presented this study, the new data on how Spanish society have changed. We have continued to work together with the Alcalá University and the legal clinic on how to identify what rules and regulations and norms exist at the national, regional, or local level, which still are detrimental for HIV people rights. We have had meetings with a major lobby, which is the Insurance and Reassurance Union in Spain, both for life insurance and service insurance. And we have initiated a process which we cannot say it's a victory yet, but we are in the process of ensuring that the current discrimination for HIV people when hiring an insurance policy that can be finished. And to do that, in this case, we need to use the Chorus region, which is very important in this country, to be able to show that beyond changing a legislation, we can show them that the life expectancy of HIV people today is very similar to the general population average, and they cannot continue discriminating these individuals because they have HIV. In 2022, we have done the Stigma Index, which is an international study which will give us a very good comprehensive overview of where we are today globally. We continue identifying laws, regulations that may discriminate against or limit rights of people. we are also educating professionals of all fields so that they are more aware and more sensitive to the stigma and discrimination that HIV people suffer. And something very important, we have become funding our NGOs projects aimed at reducing stigma and discrimination. So amongst them, I would like to highlight these, and thank you very much, but it seems that this person has a lot to do with the fact that this has been successful. So thanks to her. Thank you very much.
Muchas gracias, Diego.
Thank you, Diego, for this excellent presentation. Proud of Spain, must say.
To spend some time in a round table discussion with Vanessa, with Erika. Is Erika connected? Team?
Yes, I'm here.
Yes. Okay, it's just. Okay, I can see you. Hi, Erika. And I would, with Vanessa, with Erika, and with Diego, and I am going to ask you some questions to know your perspectives about, and I don't know where I have here. No, the presentation is, I don't need it, but. Oh, no, 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 no. Yes, I think it's okay. Apologize. The first question I have for you is, what impact is stigma having in your field, and what remaining challenges do you want to highlight? Erika, I would like to have, first of all, your perspective, what you prefer to highlight, but also I know that you are not only a representative for a very important organization, but also you should to cope personally with the stigma. So besides the issues you want to highlight, I would like to ask you about how intersectional stigma affects transgender people. So.
Thank you very much, and thank you everyone for allowing me to be with you today. Unfortunately, I couldn't be with you in Spain, but I'm glad to join online. So, you know, talking about stigma and how we as persons living with HIV and also as trans people come across stigma in different phases of our lives and throughout our lives. I just want to share first a little bit of my experience, my direct experience, and the impact it has had. You know, I was diagnosed with HIV in 1995 in Latin America. I am from Belize originally. And in the middle of a situation where there was no guaranteed treatment, and treatment that we had was only obtained through donations. So it was a difficult situation, and on top of that, the stigma, the discrimination, including from the healthcare providers who were afraid because there was lack of knowledge. And there were so many questions around HIV, accompanied by the pain of seeing my peers, my best friends, my colleagues die around me, and die in very horrible situations where their families wouldn't even claim their bodies. That level of stigma and discrimination was what we were going through then. I would love to say that what I went through in my early days when I was younger, no one has to go through it. I would love to say that it's not here anymore. Unfortunately, we're still seeing the same things. I was hearing the great advances you're doing in Spain. I really want to congratulate you for the great work you are doing. But the reality is that it's so inequitable around the world. There are parts of the world where people still don't have access to treatment. in a constant way that is a treatment responsive to the needs of the individual, and is also, you know, in participation with the individual. There's still a lot of stigma and discrimination from family, from the health sector, from labor sector. People are still being turned away from their works when they know they're HIV positive. From education, children living with HIV still are strongly stigmatized. And this is a population that we rarely talk about also. Pediatric HIV is a big issue that perhaps doesn't resonate too much. But adding to the question about multiple layers of stigma, you know, it's the level of stigma you suffer already because you're identified as a trans person, coming even from close families, when they don't accept you by who you are, by society itself. In many countries around the world, we are still criminalized. When I was young, in my country, you would go to jail for 10 years. There are many parts of the world still that key populations are criminalized, and we have to deal with that on top of other forms of stigma. I am a trans person of indigenous descent living with HIV who did sex work for survival. All those things, there's multiple layers of stigma and discrimination that trans people have to go in their life, and it shows in the hate, in the violence, and many times in death. Trans people are being killed because of hate, because of stigma and discrimination. And the lack of opportunities, and most importantly for transgender people, the lack of legal gender recognition closes so many doors, and also doors to access to treatment. And I must say, the challenges remaining and also emerging. We are seeing something so horrible happening around the world right now, which is the backlash, the extreme conservatism in countries, in governments, taking positions in the anti-gender movement that is trying to erase trans identities and doesn't even consider me as a human, as a citizen of a country with equal rights. And I think it's important to highlight, nobody wants better or privilege or special rights. We're just talking about basic human rights that prevent us from accessing health services and being able to enjoy a quality of life and dignant life. I'm going to leave it there for now.
Of course, Erika, thank you for sharing. We know, but listening to you is amazing, such things that are happening, and I want to give my congratulations to your response, your work, and your organization, because it's really amazing. Thank you. Vanessa, what are your perspectives about the challenges and about the impact of stigma in your field?
No, thank you. I think, first of all, acknowledging Erica's experience, because you put it so articulately and powerfully, and ending on the aspects of that it's a human rights issue, it's a social justice issue, and we just can't separate that. And I think that with my work as a clinician, as a doctor within HIV, what I find that we really need to highlight is about institutional stigma. And we talk about institutional in healthcare services, and just that often I think that we're in a bubble within the HIV sector, so we'll have our space where we may feel very comfortable, but then as soon as people will interact with anyone outside of that space, it all falls down, and that needs to change, and systems need to be made accountable for that, so that and there need to be processes in which people feel that they can safely feed back about their experience, because that isn't in place at the moment. But also when I think of institutions as well, wider institutions, so when talking about health inequities, we talk about the other social determinants in terms of education, housing, food insecurity. So for an example, people that I look after, they will go to the housing office, and the stigma that they will experience there is horrendous. And I actually went with one person to go and advocate for a meeting, and I was shocked. I mean, you know it, but until you see it, and you see that there's a fundamental lack of respect and devaluing that it makes you shiver. Those structures also need to be made accountable. They need to be called out, and they need to be made accountable, and we also need to educate them on to how to do better. So I think that when we think about institutions, it needs to be wider. But the other thing I wanted to highlight in terms of stigma that, you know, many layers, but something that I think really needs to be focused on is about the stigma within people's local communities. So I work with a number of racially minoritized people, and actually, you know, I call it that dual existence, where as soon as they come into the clinic, we will talk about how they're living, their lived experience, etc., and HIV is named. As soon as they go out of the room, it's never named, but it's influencing their lived experience. And one of the greatest fears that they have is community. And the thing is, if we had this conversation 20, 30 years ago, it would be the same. And so what are we doing? And within my work in community advocacy, you know, you try and educate, you try and push forward, but I think that there needs to be something in legislation, there needs to be something in standards that really say that if someone is experiencing this, if you hear of it, you see it, it needs to be eradicated. And I don't know the answers, but those are the key areas that I see within my work.
Okay, okay. Vanessa, and also you are, you have relevant publications related to various areas in HIV prevention, such PrEP and condom use and other linkage and rotation in care. What impact do you think stigma in general, and stigma in particular in health sector, has on these issues?
Many, but I think one of the, you know, the key manifestations that you can't underestimate is, and it speaks to what Erica was mentioning, just about the trauma that people have been through, and then how we as systems and services respond to that trauma, and how do we create spaces that, we talk about trauma-informed care, but what does that mean? And are we really delivering trauma-informed care, acknowledging what it is like that your community ostracizes you? What is it like that you haven't got any money, you're desperate for housing, and you're using your last bit of energy to go to a housing office, and then you're completely slapped down? That trauma and you know, the focus that we need to support people in addressing those structures, but responding to that trauma and having some healing from that trauma as well. So I think that's also very key.
Okay, thank you, Vanessa. Diego, would you like to add some experience or some thoughts about your perspective and challenges about this question?
Erica, first of all, I mean, thank you for your words, and I'd like to stress important points that you said, because as a trans woman, HIV positive, that had to leave your own country to fight for your life, to feel secure, not to be killed or whatever. You know, this is the structural stigma that it is happening in so many, many countries, And even in the security of Western countries, you in the Netherlands, and we in Spain here, that we have this frame where we can feel more secure than in other parts of the world, even here, we have stigma and discrimination that we still perceive and we still suffer. And those are, apart from the frameworks that, as we are doing with the Pacto Social, with the social pact, trying to change all those laws and all this framework that, in a way, makes stigma stronger, day by day, we still have to face many stigmatizing situations in the healthcare settings, in the education, as you said, with children. And if you are a gay man or a trans woman or a trans man, you have to cope with homophobia, you have to cope with xenophobia, and if you are from another ethnicity, then this xenophobia, I mean, all together, you know, and of course, I agree with you. It's all politics. It's all, at the end of the day, all this wave of extreme right wing that is kind of washing out everything that we have managed to conquer during all these years. So thank you for your words, because we are suffering all the things that you are saying, even in these, you know, organized Western countries.
Thank you, Diego. So we move now to the second question I have to you. I don't know if it, okay, I don't mind. Go for action now. How can we build on existing successes to move us towards zero stigma by 2030? What do you think is the next, the steps, the priority things we need to do? Erika, please, can you give us your thoughts? Where is Erika?
I'm right here. So I think, you know, it's a tricky question to,
yes.
to end for zero stigma by 2030. You know, I think there's a few things we need to do. We need to keep the momentum. We need to ensure that HIV and the issues around stigma are still in the agenda, not only in our agenda because it affects us directly, but in the agenda of national governments, of stakeholders, of parliamentarians that make decisions, in the agenda when politicians are deciding on national budgets. They should not forget, okay, we need to still combat stigma and discrimination, and it's not only about making a beautiful campaign, Zero Stigma, it's about really ensuring that we can eradicate it. But it means that we need to ensure that we really live to having community engagements and communities at the centers. Perhaps, you know, and we need to be really focused on how we will do this, because I don't think we might ever remove stigma 100% from everywhere. But there are a few things we can do. So we can ensure that we work on policy reform and change to ensure that there are protective laws. And we make sure that there are anti-discriminatory laws that cover issues around HIV and issues around trans identities or gender identities and other key populations. Move forward and fast on legal gender recognition and start to see the relationship between legal gender recognition, gender affirming care, and treatment success for people living with HIV. Access to legal redress is really important, and protection from human rights violations. Most importantly, I want to highlight something. It is that unless, in the meantime, we get to where places and hospitals and everywhere is stigma-free, there are service delivery centers led by community for community. That's a space where I can go and I feel safe. Yesterday I was in a session where I talked a little bit about some examples, and I know a colleague there from the trans clinic in Amsterdam is there in the audience. If you want to know how this is done, talk to people like that. People who go and give services in a setting that is provided for the community. And it's not that we don't need a special building. We need attitudes and people who understand our realities, who empathize with us, who provide services in a way that is appealing for me and respects my identity, respects who I am, but provides for my needs holistically as a person. Not only looking at me like, oh, this is a vector of a disease, I need to keep her undetectable so she doesn't transmit it to other people. You equals you is important and is huge, but we need to see people from a perspective of as a whole. What are all my holistic needs as a human being, as a trans person, as a woman living with HIV?
Very important things you are sharing. Erika, would you like to share with us some actions that your organization are running now or doing?
Yeah, yes. So one of the things that we're doing that I'm working at is the issues of making sure that our communities are aware of what are our human rights and what are the rights of a person as a trans person, as a person who accesses healthcare. Because many times we might take it for granted, but when you live 100% of time in an atmosphere that stigmatizes and discriminates you, you get so used to it that you normalize it. You think that is normal. When I moved, as they were saying, to the Netherlands, it was like I came to a different planet, literally. Wow. I was like, wait, the doctor talks to me and touches me when I go for, examines me and not just gives me a prescription from across the table. That was new. I'm called by my name. My pronouns are respected. So, those kind of education, enacting a literacy around human rights is something we do. And also movement building, supporting trans organizations and the trans movement to be able to respond at national and regional level, but also in global and regional structures where politicians and leaders make decisions. And the third thing I want to highlight is the engagement, the meaningful engagement, because it's not only sitting around the table. I am tired of people saying, oh, we will give you a seat around the table. No, I don't want to sit around the table. I want to lead the table. I want to be the person in charge that can tell you what to do because I have the expertise and you need to listen to me. So that is really important. And making sure that everyone that needs to be around that table making decisions is there. Not only the people who can speak loud.
Okay, thank you, Erika. Thank you. Very good work. Vanessa, what are your thoughts about how we can build towards success?
It's a hard question and difficult to follow on from Erica because, again, has put it so powerfully. But I think that momentum that Erica mentions brings, two of my favorite words, intentional and relentless. And that's what we need to be, and we need to do that collectively. I also feel that when we talk about all the social structures that are involved, and we talk about making structures accountable, we have to name the forces that are influencing and undermining. And we've got to name racism, we've got to name homophobia, we've got to name transphobia, and not fall into this political correctness that makes you just seep into yourself and say, you are racist, you are transphobic, you are homophobic in your policies, in how you deliver things, and then say, we need this change as a result of this. But if we don't name those forces, we don't move any further, and we shrink in silence, definitely. And I think as well, we talk about stigma and making sure that people feel valued. Nothing makes you feel valued more than if you've got money following you. And again, I talk about the aspects of distributive justice is that if we know who the most marginalized are, we know it, everyone here can say who they are, but then can we say that the resources follow those? Can we say that the organizations that are supporting those people to live life in the way that they should, are they getting the funding in a sustainable way to do that? And I think that we reflect on it, but that has to shift significantly. And then in parallel, with that whole aspect, you know, we haven't even touched on peer support and how influential that is. But we've got to make sure that we are pushing against and supporting those organizations to deliver and support that holistic life, as Erica has mentioned, but also in parallel, making sure that we are also campaigning against the legal frameworks, because without those standards and without those accountabilities, nothing can change.
Okay, thank you. Both Erica and you have talked about the relevance and importance of peer education. And we have here Diego that leads a very important project in Seville, and here in Spain we have peer education programs. Then I've moved to you, Diego, but first I would like to ask Vanessa, because your profile is very extensive, and I don't know if are you working in a hospital? No? Okay. In your hospital or in other hospitals in your country, are you conducting peer intervention in healthcare settings?
Definitely, and I have to say that having peer support within my service has transformed my care.
Okay.
And I don't say that lightly, and I know I've got some colleagues in the audience, but it has, because so one of the clinics that I led on was the need to find clinics, so those that were having difficulty engaging in care. And there's only so much that I could do as an individual, that the social worker can do, that the psychologist can do, having peer support actually within the clinic, so that someone doesn't have to go and seek and leave the building and then decide against engaging with peer support. They're right there for you as you need it in real time. And that has been transformative. So yes, we do have a number of peer education services, but also embedded with our services as well.
Okay, okay. Diego, would you like to add your input to how we can go towards zero discrimination, your work and your thoughts, and you are a very important person. I know you are tired.
I buy completely Erica's words. I mean, this is the pathway. So Erica, nothing to add. I mean, she's got the points of what can be the agenda. And I mean, we are lucky here in Spain because some part of that agenda that Erica has verbalized, we are working on it or even has become a reality. So, but definitely, your agenda is our agenda. I mean, it's the agenda of all of us that we are living with HIV. So yes, these are the things that we have to do.
I don't know how do you think about, but my impression, because I study and work in stigma, is that we need strengthen, my English is not very good, apologize, strengthen, our work and our networks at that international level, or as the much level we can, because maybe we need to have more similar measures to compare or share actions, or what do you think about our international networks? I know that I am based in Spain and I am very, very busy, and I usually don't have time to go to other countries, but what do you think about the international joint efforts to address stigma? Erica, would you like some thoughts or experience?
Just very shortly, and if I can say one thing, is that it's doing amazing work, but it's big time underfunded. It relies in voluntarism, and it doesn't value the expertise of community and the movements. I think the movements are doing such an amazing work, and we have seen some advances, some very slow, some faster, some still behind, and unfortunately a couple of countries taking step backwards in regards to issues of human rights. But I think the more we work together, we are stronger, and we need to continue supporting each other in the different movements, in the new tools, in the new evidence that comes out, and how we can use them for advocacy. Things like having anti-discriminatory laws in countries, being able to decriminalize both LGBT, but also issues around people who use drugs and sex workers, and also championing and also living U equals U. It's not only a message, it's not only about having condom-less sex. Whoever wants to have condom-less sex, amazing, please do if you are undetectable, but know what, educate yourself around it. But it's not, U equals U, it's not only about that. It's such a powerful tool that in my case has helped me alleviate any feelings of fear that I might have. I am married to a husband who is HIV negative, and U equals U has brought peace to our relationship. So how can we ensure that everybody around the world has access not only to the high quality and constant treatment, but that they live free of fear of stigma and discrimination, free of fear of being killed, and also enjoy the benefits of the latest scientific data and outcomes and tools available for everyone.
Thank you, Erika. Vanessa, any thoughts?
Erica, I keep saying that it's difficult to follow you, but it is. I think that Erica's really covered it, and I think I feel the difficulty is that we know, and it's being articulated, and we've got to ensure that it's followed through, and it's enacted. That's the issue. I don't know. Yeah.
Leo, anything to add?
No.
No?
I think I've got three powerful women here that are saying lots of strong words and truths. Nothing to add. Only to support those words. Yeah.
Okay. So we are on time. Last night I had a nightmare because we have a very eat a lot dinner. And my nightmare is that I forgot my watch and I follow the session and the session go out of time, but not. We are on time, so I can move to the next section without fear. So now I think it's time for the attendance, I think. Okay, yes, it's time. Es tiempo para que la...
Well, I think it's time now for the participants to be able to ask questions, to express their opinion, and speakers, and ask questions to speakers. And in the meantime, you do please use Slido. So good to go and think if you have any questions. And in the meantime, Julia, yes, if somebody publicly wants to take the floor, we have a mic here, not only in the application. So thank you, Julia. I had completely forgotten about the microphone. I took my mask off with the excitement. She is so applied. Well, thank you very much to the four of you. It has been exciting to listen to you. There's a word that Diego mentioned on nuances and of how discrimination gets into the regulation. Nobody says a person with HIV cannot go into an elderly home care. They don't say a person with HIV cannot go into the army. They say that a person with a disease that affects the immune system, who needs treatment chronically, and therefore reviewing the regulation is not only about looking up HIV/AIDS in the law, when you do the review, you need to look at the rules that are designed to discriminate and make it acceptable, because you don't think that you are discriminating anyone if the words are an euphemism with subtlety, and they are only a euphemistic. So it is true that discrimination goes in through subtle words and subtle wording, and we learn a lot when we review the regulation. So it's just a thought that I wanted to share with you. And I also want to thank you. Yes, what Julia has just mentioned is very important. Indirect discrimination. We are hearing about countries where discrimination is indirect, even, and in other countries it's more direct. But indirect discrimination is based on laws and regulations, and it happens everywhere, so we need to review our laws. Thank you, Julia, by the way, for the hard work you are doing at the ministry. I think we have questions, right? So I'm going to read them.
Answer if you feel that is under your expertise. What could be done about the stigma within healthcare settings? I hope, Vanessa, you are the best.
So I think, first of all, and probably good to highlight some work that we're doing in the UK. It's in its formative stages, but because, first of all, I think that healthcare settings respond to data. And so managers within sectors, they respond to data, and then they respond to, they respond to standards, and they want to adhere to a standard, and if they fall short of a standard, they may be penalized, whether it's socially or in terms of funding. And so one of the things is, I think, asking about stigma, specifically HIV stigma, but within healthcare settings. And in the UK, one example is that we had a survey within my own NHS trust that was not led by me, but by some fantastic colleagues, and it showed high levels of HIV-related stigma within the whole trust. And what that has done now is that it has put it on the agenda within the hospital trust. But then the next step is, what do you do with that? And so it is about, education and training, but it moves beyond that. What happens if people still report stigma? What happens just because you listen to something? Is it translating into improved behavior? And so, again, one of the things that's happening within Fast Track Cities London is we are in the midst of developing a healthcare charter in which organizations are going to be made I say accountable, I think that's important, but there will be a specific set of criteria, and they have to meet it to show that you are a HIV-friendly and empowering service. And so I think education, and I think ways to make people accountable, but measuring the level is important, and then giving that information as well.
I completely agree with you, and I think it's very important to reduce stigmatizing attitudes, the contact with people with HIV. I don't know in your country how it works, but here in Spain, people with HIV, our care is done through HIV specialists, and in our studies we can see that as much contact with people with HIV, the lesser negative attitudes, and we need here, at least in Spain, to think how to connect more other specialities with people with HIV. I don't know in your country.
The same in the UK, and I think the same globally, actually, definitely.
Yes, and other lesson we have here is that in healthcare setting, those professionals, for example, I don't know how to translate, maybe nurses, auxiliary of nurses. Can you help me, Diego, with English? Thank you. Auxiliares de enfermería, other specialties. people with less education, healthcare
Mm-hmm.
professionals with less
Different
degree.
bands,
I don't know if I can explain. A whole worse attitudes than those with hikers. So the hikers, the best, the first, can do a very good work.
I think it really emphasizes that it just can't be education to doctors and nurses. It's got to be everyone within the healthcare system that interacts with another human being needs to have this education, definitely. Mm-hmm.
Okay.
May I add something? Because when we are talking about the stigma in healthcare settings, we must also take into account that we anticipate the stigma.
Yes, we anticipate.
Sometimes we are not going to suffer it, or the environment or around us, there's going to be a welcoming environment whatsoever, but for our previous bad experiences, and it's like in our DNA. And so when we go to a new healthcare setting, we anticipate that we are going to suffer stigma. So, and sometimes we should kind of go both ways to solve the problem about the stigma in healthcare setting. One is the real stigma because of lack of information or prejudice or all those things that still happen. But also on our side, me as a person living with HIV, sometimes is my my lentilla, my ear, my lens, my eye lens. Now, sometimes I anticipate that, I don't know why, but I think, okay, I've gone to the dentist before and I felt stigmatized. So maybe I change doctor, and the next doctor is someone, you know, really informed, really nice, with a good attitude. But the way I go there, I remember my previous experiences, and I anticipate I'm going to be treated badly. So, are you HIV positive? No. Do you have anything to declare? No. So, we anticipate. So, we have to work both ways.
I think that's such an important point. I think that the anticipation is so powerful on many, many different levels, and I think we need to acknowledge that and then think about how we support people to, because it's a reframing in thinking. Again, we're all human. We have a negative experience where our bodies just naturally respond to clench and be fearful. So how do we say that, you know, not everyone is the same? So we're asking society not to other, so then we need to think about how we don't want other people to other as well. And I think that one of the things that's doing some community engagement is what to expect from healthcare, and then what healthcare expects of you as well. Yep. You know, and then having it like a two-way thing, because that's how you build a relationship. So completely agree. Yeah.
I don't know.
Can I just add
if
really fast? Yes, Diego shared something about how you expect it already, and that's a mechanism that many of us have used to protect ourselves, because we have been through such bad experiences in life that we need to have this protection, and then we can relax after if we see that things are okay. But you know, when it comes to interventions, I do agree that they should be for everyone. Even for the person that cleans in the hospital, that takes the prayers, the food, everyone. Because sometimes the security guard is the one that stigmatizes and discriminates you the most from the moment you are in the door. For physicians and nurses, I think that those training and sensitization should be built into their curriculums. So before you even graduate and start practicing, you already have been through them, and you've been bombarded with training. Hopefully, it will seep into some of those hard brains. And reports should have a closure. We should try to build a culture of accountability and deal with the power dynamics between healthcare provider and client.
Okay. So we go back to the questions of the audience. Where are Not a question, but very well said and well done, Erika. Erika, for you. There are other questions. How can, maybe in the same area, how can we better educate healthcare professionals to listen us, to understand us, and be better informed and not stigmatized? Maybe you can add some to our previous discussion.
So I think it builds on what we said earlier, but I think, you know, the key words here is us. So us need to be within that education. And so when we design these interventions, let's just remember again who is at the table and who, as Erica said, is leading the table. And being really, really intentional about that, because we've got to ensure that we do create the spaces for people to lead and to partake and to do it authentically. So I think, to me, that's the key. It's when you're designing those interventions and you're working with healthcare professionals, do not accept that power is not shared. You know, and you know, so if you're asked to comment on something, no, until I know that you are going to be working with me in this equitable space. That's just my reflections. Yeah.
Some additional thoughts from Diego or Erika about this question?
You know, I think one of the things that we should think here is that it is not my responsibility to educate any doctor. They go to school and they get well paid.
Yes.
And they don't need me to be there as a volunteer. I think, you know, many times I've come from way back, and it's still happening in many countries. They take a group of people living with HIV, or somebody from key populations, to share these testimonials and stories to doctors in hospitals, and, you know, touch their hearts and these sad stories. I don't agree with that. Those, if you want to look at that dramatic story, put on the soap operas, watch a Mexican telenovela, it's the same thing. What we need is empowered people to not educate doctors, to demand. We need to demand what we need.
Yes, I completely agree.
One of the things we have realized, for example, with the peer educator program when it's happening in the hospital settings, is that the work of the peer, they are working with the infectious disease unit, with the pharmacist, with the nurses, with the administratives, because sometimes the administratives have a lot of power in giving the appointments and all that stuff, so don't forget them. Social workers, etc. I mean, having an HIV peer there, what we have found here in Seville, where we are in the 3 hospitals, is that at the end of the day, you see a change in the attitude and how, you know, that presence there starts moving things. And I'm sure that, you know, before it started in 2004, because it's a very old program here in Seville, the peer education program started very early in 2004, and fortunately we keep on doing it. But what we have realized is that maybe it's because of that we have, you know, such good attitude and so little, bad attitudes or stigmatizing attitudes, because we have educated without knowing that we were educating them, or without having the feeling that we were educating them. Because, I mean, they don't learn those things in the university, Erica, and they are not going to learn it. Forget it. I mean, I did podology. I'm a master in linguistics, and then I'm so crazy that I did podology, you know. And can you imagine? They were teaching me in podology when we were, you know, learning surgery and all that stuff, that HIV, wow, and I was HIV positive. And you see the notes from the School of Medicine, and I laugh at them. So, and it was just a few years ago, 10 years ago. So, I mean, forget, it's very difficult to end up. So maybe we can use the things we already have to make those little changes.
I am remembering last week we had our national conference in Bilbao, and we organized a session with students, healthcare, of different healthcare profession students, mainly physicians and nurses, and they demand that they feel the education need to improve a lot, but not only in specific knowledge of HIV, but mainly in general capacities, in general ability, communication, how to manage stress in an acute situation, how to a broader, and they feel disgust with the, I don't know, in a university setting, more people, there are a lot of, how do you say, catedráticos, don't say senior professors that don't move of the same material, the same things, the same feelings, so we need to move towards a more inclusive and a more, no?
Yeah, I firmly agree. I think that, so some of the work that I do is with you know, equality, diversity, inclusion, and there are so many organizations, so many universities that are throwing EDI out there, but what does that actually mean? And particularly for medicine, and that you want to create socially minded individuals that are going to be caring for a globalized world. And within that, that means there are certain things that have to be in your curriculum, and it's just not there now. You know, there's so much work about imagery that is just not representative diversity, but in many, many layers. So I do think that we have a long way to go with education and the content and how it's delivered.
Okay. Yeah. Yes. Those, we have more questions. I don't see, can't see it. Please, can we show the question? Okay, thank you.
Oh, more.
Is there a standard framework to measure stigma in different countries, and framework you measure interventions? Wow, it's a very, very complex question. What I can say, I hope Vanessa can help me also. The last review I read, no, I perform, I identify near to 80 frameworks about felt stigma and about internalized stigma, and more than 100 different measures to measure stigma. So, but it's not, I interpret it positively because it showed the interest in the continuous study of stigma, and there are things that are very, very well consolidated in all the frameworks. Vanessa showed a framework, one of the last ones, but the drivers, the facilitators, the types of stigma, there are different types of stigma that are adding, for example, not only stigma by association, for example, that is less studied than other kinds of stigma, that, like a structural stigma, or not only internalized stigma by people with HIV, but also the stigma that our families or our friends, our people of reference internalize the stigma also, and it is not well studied. It's not enough studied the intersectionality of stigma, so the framework is growing, is my opinion. Is the amount of framework is not a bad thing, is the interest that the community had on stigma. What do you think, Vanessa?
No, I agree. I think the issue is that it's complex and it's a social phenomenon, and there's so many intersecting layers to it. So then every framework wants to capture that. So as you do more research, you want to capture more of the experience. But I do feel that standardization is important, because so you first of all need to share, like we're doing, because I'm sure there's people here that have been looking at your great work and thinking, how can I apply that in my country? But then how do we measure that we did the same thing in the UK or Ghana, and it didn't have the same impact as Spain. So why is that? And we don't. To do that in a robust way, you need something standardized.
Yes,
so
yes,
it would be fantastic that there is an outcome of having, even if it's not everything, a core stigma framework and measurement that is relevant to each country, and then there's local
to compare.
Exactly, and then it's bespoke for your country as well.
In research, we can dip in different,
exactly.
but at least agree in core indicators that we can share, and I think is important, and agree. Some comments of the other panelists about the frameworks.
Oh, I think Erica.
I would like to step in on this one, because I think there is already something that can be applied in many countries that is comparable, and that's the Persons Living with HIV Stigma Index. And it is something that was prepared with communities, from people living with HIV. It has communities at the center, and it is implemented by people living with HIV. So it's community-led research, and it's, was developed by different some organizations, GNP+, ICW, UNAIDS, with the input of people living with HIV, and it has come through several iterations and developments, and there's the new Stigma Index 2.0 at the moment, which many countries are applying. So if you want to take a look at that, that's the number one I would go to.
Erika, we are in Spain starting, we have just validated the items, and we'll start the data collection the following 2 months. But I think we need to rethink a little because it's too long. So it's very important because we are going to capture a lot of information, but I think we need to do intermediated, shorter things to have more indicators easily. No, it's only a thought. No, we can discuss it.
And I think it would be great to have like a societal index as well, that can be across countries. But
okay, any thoughts, Diego? No. I don't know if I think we are on time. I don't know if there are any important questions that we should, maybe if people need some clarification on other question, can send us some email to answer, do you think, Tim? Okay. So it's time to move to the final of the session, or near to the final. Yes, call for action to close. I am rounding, trying to see on the screens. Ok. Voy a explicar en castellano ahora porque es más fácil para mí, para terminar, y como está la diapositiva en inglés.
Slide is in English. As we have seen at the end of the session, and as Vanessa said, this is a complex issue which has different intersections, and it needs a strong response, united response, and coordinated and complex response. There are many things to do, but one of them, as we have discussed, is that we must improve data collection and reporting to the global indicators so that we can have a comparison of the situation in different countries, and so we can monitor evolution and in which countries we need to improve our answer and response, and in which types of stigma specifically. Regarding structural discrimination, we have lessons that we can transfer from other countries which have less punitive laws and where they have worked to eliminate or the restrictive and punitive laws, such as Spain or such as the UK. We have listened to important experiences from these two countries, and we need to promote laws that support equality and also eliminate those that don't. Stigma, discrimination, healthcare settings. We need to have strict studies. We need data. And as well as common indicators and procedures so that healthcare settings know how to collect data, and that is how they have told us, at least in Spain. We need to improve support to healthcare centers with resources so that they can give high quality care and respond to the proposals from Erika and Vanessa of empowering, training, and having the resources and support they need. And of course, we need to strengthen the role of peer education in the healthcare setting. We also need to improve interventions aimed to reduce stigma. Stigma is complex and it works at different levels, though we need to do it at the different levels: intrapersonal, interpersonal, institutional, community, structural, and above all, this can't be done in one place. We need to work on it together and in coordination. And we also have to improve research, find the evidence of interventions that are effective. So we need to focus there. Last but not least, well, it's not the last, but I have 0 seconds left. We need to work on understanding better and measuring intersectionality of stigmas, because it's not worth it that people like Erika are suffering, not only because of HIV, but also because of having other intersectional stigmas that create a new inequality, which is way bigger than the others. So lastly, we know that reducing stigma must be at the heart of the HIV response, that it must be a priority in funding, policy making, research and programs. And I want to congratulate Julia del Amo, the National AIDS Plan in Spain, and also the Spanish Ministry of Health, Carolina Darias, our minister, for placing stigma at the center of the presidency. She has said that already. So thank you, Minister Darias, and your team. So let's move on to zero stigma. So I would like to leave your proposals on how we can change this situation. Use hashtag #ZeroStigma in your social media to share your plans and proposals so that we can bring them together and find the goal of zero stigma in 2030. I don't know what I have to say here, so I just needed to ask you to send us this in Slido, and I think that's it. Is that okay? Yeah, we finished.
Las mandáis las propuestas porque estoy en tiempo. Muchas gracias, Erika. Gracias a todos los panelistas. Gracias a Viv. Gracias al equipo por la ayuda.
Gracias, Erika. Thank you.
Thank you, Erika.
Gracias.